All right, we'll go ahead and get started. And I just have one short announcement before I introduce today's speakers, and that is that we're accepting letters of intent for the LMI Pilot Award, and those are due March 20th. And in the chat, I put a link to the LMI website with information about the Pilot Award. So this is an award for $75,000 to support a project for 1 year. And please feel free to email me if you have any questions about the Pilot Award. And with that, I'll go ahead and start introducing today's speakers. So today it's my pleasure to introduce our speakers for a joint presentation. So the speakers are Dr. Sibley and Dr. Hao. Dr. Sibley is an assistant professor in the Department of Radiology at UT Southwestern in Dallas, Texas. He earned his MD and completed residency in radiology and nuclear medicine at UT Southwestern. He then completed a T32 fellowship in body MR imaging with a research focus in lymphatic imaging at Stanford University. Dr. Sibley runs the Multidisciplinary Lymphatic Disease Conference at UT Southwestern, and his research focuses on developing lymphatic imaging tools for quantifying and characterizing lymphatic disease. And Dr. Hao is a professor in the Department of Material Science and Engineering at UT Arlington. He earned his PhD from MIT in 2003 and completed postdoctoral training at Johns Hopkins University before joining the UT Arlington faculty in 2005. With a research career spanning 2 decades, Dr. Hao has published over 75 papers in peer-reviewed scientific journals and holds 2 issued patents. His current research focuses on radio-nanomedicine, where his group leverages inorganic nanoparticles to develop sophisticated delivery vehicles for medical radioactive isotopes. And recently, his work has pioneered new applications for this technology in PET lymphatic imaging. And the title of the presentation today, well, Carson's is Imaging Features of Complex Lymphatic Anomalies, and then Dr. Howe's will be Developments in PET lymphatic imaging using radio-nanomedicine. With that, I'll turn the seminar over to Dr. Sibley.
Great. Thank you so much, Dr. Dillinger. And probably one of the highlights of my training was also working in Dr. Dillinger's lab many years ago. So thank you for the kind introduction and the opportunity to speak today. So I will be discussing the imaging features of complex lymphatic anomalies. Here's a brief overview of what I would like to discuss today. I'm going to briefly touch on the lymphatic system and complex lymphatic anomalies, and then highlight the challenges that we face as radiologists in imaging the lymphatic system. And then we'll go through in detail the imaging features of CLAs, and then I'll conclude with really the clinical needs that we have and that we face in clinical care for these patients. And I think that will be a nice transition to Dr. Howe's talk. So the lymphatic system covers our entire body, and it's an active system with pumping mechanisms. It plays an important role in fluid regulation and for the immune system. Unfortunately, probably most physicians in their medical training will only receive about 30 minutes of training in the lymphatic system. And so there's really a large opportunity and a gap in terms of understanding lymphatics and lymphatic diseases. So again, about 10% of the fluid in the blood circulation will seep out through the capillary network and will be returned back through the lymphatics. It's interrogated by the lymph nodes, and ultimately it drains back through the thoracic duct into the blood vasculature. And there's approximately 8 liters of lymph fluid that's produced per day that must be returned by the lymphatic system. And there are many diseases associated with the lymphatic system, and the list continues to grow. But today I'm going to highlight one particular set of diseases, and that is complex lymphatic anomalies. So complex lymphatic anomalies are lymphatic malformations that have structural complexity. They involve multiple systems, and there's functional impairment of the lymphatic system itself. These can be associated with life-threatening complications, including immune compromise, sepsis, malnutrition, bleeding due to coagulopathy, and respiratory failure due to chylothorax. The International Society for the Study of Vascular Anomalies characterize complex lymphatic anomalies are traditionally into four groups. These include generalized lymphatic anomaly, GLA, Kaposiform lymphangiomatosis, KLA, Gorham-Stout disease, GSD, and central conducting lymphatic anomaly, CCLA. But recently, in 2025, there was an additional subgroup called generalized lymphatic dysplasia, GLD, that was added to this list as well. So as a radiologist, there's many challenges that we have to overcome when we want to image the lymphatic system. One is the size of lymphatics. So if we look at the thoracic duct and compare it to the aorta, the thoracic duct, the largest lymphatic, is approximately an order of magnitude smaller than the adjacent blood vasculature. So therefore, we often think about trying to get a contrast agent into the lymphatic system. Also, as I mentioned before, the lymphatic system covers a large area of the body, and there may be a large area that we want to interrogate when we're evaluating a patient. So that can be challenging from a radiology perspective. Also, opposed to the blood vasculature where we can get IV access and inject a contrast agent, and then it circulates throughout the body. For the lymphatics, it's a unidirectional system. So we have to inject our contrast agent upstream of the lymphatic vasculature and structures that we want to visualize. And finally, there are, for indirect injections of or indirect enhancement of the lymphatic system, there's specific contrast requirements for the contrast agent that will allow us to visualize the lymphatics. And most of the FDA-approved contrast agents are not optimal for lymphatic imaging. So there are many modalities at our disposal when we want to evaluate CLAs. Ultrasound may be the first imaging modality that patients encounter. For example, if there's a soft tissue mass that's being evaluated, ultrasound is also often the go-to, especially in the pediatric population. This technique has a limited field of view, so it may be difficult to differentiate simple lymphatic malformations from more complex lymphatic malformations. But what we'll see is avascular anechoic cystic lesions on ultrasound. We can also use radiography, which is useful for evaluating bone lesions. So if we're evaluating the osseous structures and we see a lucent lesion, that can be indicative of CLA involvement. However, when we're working up a patient, there's a broad differential for lucent lesions, and that includes multiple myeloma or multifocal osteomyelitis. But radiographs or x-rays are really great for evaluating the bones, and particularly evaluating for pathologic fractures. Once a diagnosis of CLA is established, then if we know that there's osseous involvement, it may be suitable to monitor the osseous lesions with radiographs as well. But probably the main workhorse and the primary tool in diagnosing and evaluating, excuse me, CLAs is going to be the MRI. This allows us to characterize osseous involvement, if any pleural effusions, cardiac, pericardial effusions, any ascites, soft tissue masses. We can identify multiple organs involvement if that is present. And so there's sort of two general techniques that we consider in MRI. One is just a T2 weighted image where we can see fluid and dilated structures. And then two is a dynamic contrast enhanced MR lymphangiography, where we're going to inject the lymph nodes and evaluate the central lymphatics. So when we look at a list of imaging findings that are used to describe patients with CLA, there's several overlapping features. So we may see central conducting lymphatic flow abnormalities. Again, that's best evaluated with an MR lymphangiogram. We can see effusions, bone cortex destruction, central body soft tissue lesions, visceral cysts, or peribronchial soft tissue thickening in the lungs. And from a radiologist perspective, you can imagine that these deciphering these categories, these types of CLA can be challenging based on imaging features alone. And I just want to highlight that really it's best for these patients to be evaluated by a multidisciplinary team and to have a multidisciplinary approach to their care. However, radiology really plays an important role for characterizing the disease. So let's talk about generalized lymphatic anomaly. So this is a multifocal lymphatic malformation. Commonly, it involves the lung, the bone, spleen. I want to highlight that the bone involvement for GLA spares the cortex, and so these patients will have a decreased risk for pathologic fracture. These patients can develop chylothorax, which is associated with poorer outcomes, and just like really all the other CLAs, MRI is the modality of choice. So here we have a 3-year-old patient who's presenting for increased work of breathing. We have an axial CT, CT of the chest that shows diffuse interstitial thickening, which we see in these yellow arrows. As well, we have multiple indeterminate hypoattenuating lesions in the spleen, where these blue arrows are. Here, these little small hypoattenuating lesions in the spleen. Lung biopsy confirmed dilated abnormal lymphatic vessels. We had a follow-up MR spine, which showed interstitial thickening of the lungs here at these yellow arrows. We see these T2 hyperintense signal in the lungs. We also see T2 hyperintense foci in the spleen here, these bright structures. And then we also see lesions involving the vertebral bodies at this blue arrow in panel E. So these findings are consistent with GLA with pulmonary, splenic, and osseous involvement. For Kaposiform lymphangiomatosis, this is an aggressive and distinct subtype of GLA. On pathology, we can see clusters of spindle-shaped lymphatic endothelial cells and extravascular hemorrhage. Effusions are typically present. We can see soft tissue infiltration of the mediastinum and hilum. And we can also see infiltrative soft tissue thickening along the bronchovascular bundle and the interlobular septal thickening. So here we have a 67-year-old patient with a history of KLA that was complicated by hemorrhagic ascites. Excuse me. The CT angiogram in panel A demonstrates recurrent chylous effusions in loculated components. That's these green arrows. We also see multiple mediastinal lymphatic malformations where these yellow arrows are. And then on the CT abdomen pelvis, we see chylous ascites with loculated components. That's the blue arrows, and splenic lymphatic malformation, this red arrow. And then we also see radiodense material, these white dots in the retroperitoneum, and that is sequela of a prior lymphangiogram for embolization. So next we'll talk about Gorham-Stout disease. So in this disease process, we'll see multiple intraosseous lymphatic malformations that specifically have progressive osteolysis involving the cortex. This is also known as vanishing bone disease. We can follow these patients with radiographs. And if these patients have thoracic involvement that results in chylothorax, This is associated with poorer survival. So here we have a patient presenting for right lower leg pain. And we can see in panel A, this is a radiograph of the right tibia and fibula, which shows a lucent lesion with endosteal scalloping and associated pathologic fracture here at this yellow arrow. On panel B, we have an MR chest that shows a T2 hyperintense lesion in the supraclavicular soft tissues and these yellow arrows. And then we also have an expansile left scapular lesion here at this red arrow. The cortical bone loss and pathologic fractures are consistent with the diagnosis of Gorham-Stout disease. For a central conducting lymphatic anomaly, these are anomalies involving the central lymphatic vessels. So again, I mentioned before the thoracic duct and the cisterna chyli. These can be divided into primary and secondary. The primary is caused by the issue is in the lymphatics themselves primarily, and this is associated with syndromes such as Down syndrome. In a secondary CCLA, we'll actually have a different primary issue such as congenital heart disease or elevated venous pressures. And so dynamic contrast MR lymphangiography is really key for characterizing these patients. It can help us identify leak and reflux of the lymphatic flow. It also helps us to guide interventional procedures such as embolization. So here we have a 10-year-old patient with no significant past medical history presenting with recurrent chylous ascites requiring frequent serial paracentesis. DCMRL injection of the inguinal lymph nodes on a delayed phase demonstrates absent flow at the expected location of the thoracic duct insertion into the brachiocephalic vein here at this red arrow. And then we see reflux of lymphatic fluid into the left neck at the yellow arrow and into the mesentery, the green arrow. And this patient has leakage of lymphatic fluid into the peritoneal cavity at these blue arrows. And in the absence of any inciting event, these findings are consistent with a primary central conducting lymphatic anomaly. So this patient is a 14-month-old with a history of critical coarctation of the aorta that was stented. This patient also had bronchopulmonary dysplasia that required mechanical ventilation. And this patient had post-surgical neck swelling on the left greater than right. Dynamic contrast MR lymphangiography with injections in the inguinal lymph nodes demonstrates absent flow at the expected location of the thoracic duct insertion at the left brachiocephalic vein at the red arrow. We also see reflux of lymphatic fluid at the left neck, along the patient's head, along the left face, and also involving the right neck as well. So these findings are consistent to a secondary central conducting lymphatic abnormality, likely due to the increased thoracic pressure from the mechanical ventilation that this patient was receiving. Finally, generalized lymphatic dysplasia. These occur from germline pathogenic variants in a few genes that have been described in the literature. These patients initially present with non-immune hydrops fetalis. These patients will have widespread lymphedema with visceral organ involvement. Oftentimes they'll have intestinal and or pulmonary lymphangiectasia and effusions of the pleural space or the pericardial space. And from a radiologist perspective, there's really an opportunity to better characterize and understand the imaging features of these patients specifically and how they compare and contrast to the other CLA types. So in conclusion, CLAs have overlapping features that make imaging interpretation challenging. More than one CLA may be present in a given patient. MRI currently is the primary driver in imaging workup, and dynamic contrast MR lymphangiography provides anatomic and functional information for diagnosis and interventional guidance. Now I'd like to highlight what I view as the clinical need for these patients. As you can see, imaging, we have multiple imaging modalities and we can provide a lot of information about the state of these patients, but I think there is an opportunity to better characterize the disease process in itself, and to better characterize the lymphatic system. So we need tools that can accommodate a large field of view, that have high spatial resolution, that have lymphatic specificity. And really, I think what's needed is quantitative imaging where we can um, with, assess lymphatic function and disease severity. And with that, I'll stop here and hand it over to Dr. Hao.
Good afternoon, everyone. Thanks for having me here today. So today I will be talking about this our effort to develop a better or much better imaging tool for lymphatic disease. Like on the Carson's last slide, we try to meet this clinical need. Specifically, we try to use PET, the positron emission tomography, to do lymphatic imaging. The PET, they use the radionuclide for the imaging. But this radionuclide has this special property, these isotopes emit positron. Positron is anti-electron. So when this positron travel, it can travel a short distance inside the tissue, usually just a couple of millimeters. When positron meet with the electron, there will be a annihilation. So annihilation basically is the two particles disappeared and create energy. This energy is gamma ray or X-ray, so X-ray photon. Because of the physics of the conservation of momentum, this annihilation event will simultaneously create two photons, and these two photons just go to the opposite direction. They are is 180 degrees apart. So one event will produce a line like here. See, like here, this line, and you can see by just two lines, you can pinpoint this point. So because of this unique physics of the positron emitting nuclide, so that make this PET imaging very sensitive, and it has very good spatial resolution. So here is the comparison between the PET imaging and commonly used another radionuclide imaging tool for lymphatic imaging. It's called lymphoscintigraphy. So PET has a much higher sensitivity than LSG, and much better spatial resolution, and it can do true quantification. So that's the Carson just list all this the clinical or mad clinical needs. So actually PET is widely used for cancer patients, for the patients with neuron disorders, for the patients with heart problems, but not for the lymphatic disease. So that is unfair. So we try to make the PET for lymphatic disease imaging. So then the patients can also benefit from this advanced imaging technique. The reason why PET is not used in lymphatic imaging, that's because the currently available these PET agents, they are developed specifically for this cancer, for the dementia, for the cardiology. So these agents will get into bloodstream, and a very small portion will end up in the lymphatic system. So current PET agents practically is useless for lymphatic imaging. So then we try to develop a lymphatic specific PET imaging agent. This is another unmet need Carson listed. So our agent is this pegylated copper selenide nanoparticles. So here we use PEG. This is a polyethylene glycol. It's a FDA approved, commonly used polymer for coating drugs like the mRNA COVID vaccine. That's the key component in that vaccine is a PEG. We use PEG to cap inorganic copper selenide nanoparticles. This is the copper selenide nanoparticle. This is the electron microscopic picture. It has the size is about 7 nanometer. Well, when we put a PEG, this zigzag thing, on the surface of these nanoparticles, actually the inside the physiological fluid, this particle appear much larger. So we call that hydrodynamic diameter or the hydrodynamic size. So this size is with PEG. It can increase from 6 nanometer to 15 nanometer up to 75 nanometer for the hydrodynamic size. This size is the key for the lymphatic specific this property. This size is too big to get into bloodstream, but it's still small enough to get into lymphatic system. Actually, Carson also showed a slide. This is the requirement for the lymphatic specific imaging agent is within 10 nanometer to 50 nanometer. So then we design this imaging with the aim for the clinical translation. So here we have a copper and selenium. Actually, both of these elements are micronutrients in the body. Also, this in organic nanoparticle is biodegradable. In the body, it will degrade into copper and selenium ions. Then we made this agent. Then we tested in a healthy mouse model with two distinct sizes. One is this PEG 800, and the size is about 16 nanometer, and another is PEG 5000, size is about 57 nanometer. So we inject this agent into the hind paw pad. You can see this agent drain from the injection site to the popliteal lymph node, then sciatic and iliac, and the gastric lymph nodes. This is we consider is central lymphatics. Then get into the liver. So these two sides show different kinetics. So for small particles, this is small particles. You can see like here is 60 around 66 minutes post injection. The small particles, you have substantial liver uptake, but the large particles is it's still very small. So then also we see is the larger particles actually they get slowly get into this peripheral lymphatics. Here the 5, this is axillary lymph node, and 6, this is the inguinal lymph nodes. For the small particles, there is this periphery lymphatic system. We have very little uptake. So because these nanoparticles quickly get into the central lymphatics. So we can see this is the lymphatic specific. We have this property. We don't see much uptake in the blood circulatory system. There's not much in the heart. So I think we got lymphatic specific the agent. Then to further increase improve the imaging quality, actually we did the injection through tail, is a subacute tail injection, inject the agents through tail. So the injection site is not in the field of view of this image. So you can see this is we sum up all this imaging for 1 hour. We got this, so you can clearly see this is sciatic lymph node. Here is iliac lymph node. Here is the gastric lymph node. But one particular things make us very interested. That is, if you look at this here, this these two these two sciatic lymph nodes, they are seemingly they are breaking. So this is something we haven't seen in literature or in any report. So we are curious about what's going on here. Then we did the quantitative analysis of these two lymph nodes. This is the activity was here. This is the time and activity curve, time curve. We can see, especially on this area, these two sciatic lymph node, they show this waving behavior. So you can see here. So actually, this like lymph node is pumping. We say this is pulsatile lymph flow through lymph node. This behavior has been predicted by mathematical models, but never been observed in vivo. So we think this is the first direct observation of the pulsatile flow inside lymph node. Then we did 4 mice. This particular mice is very interesting because here we can clearly see the lymph vessel link. This is a sciatic lymph node. This one is a iliac lymph node. So here is a lymph vessel. So this is the dynamic imaging. We can see the lymph flow through lymph vessel. This is because for this particular mouse, they almost all the radioactivity goes to just one sciatic lymph node. Previously, they go to 2. So that make the activity very high. So in this case, we can clearly see the lymph vessel linking between 2 lymph nodes. I believe this is the first time we use this. We use PET. People use PET to see lymph vessel. Then again, we did the quantitative analysis. So here we can see this lymph vessel follow the sciatic lymph node, this kinetics. So I think that's makes sense because this lymph vessel basically is the outflow of the lymph from sciatic lymph node. The agents get into the sciatic lymph node, then flow away from the sciatic lymph node. So we say this is the lymph vessel mimic the lymph node dynamics. So encouraged by these results, then we went for to see our agent or technology can detect this the lymphatic disease. We use genetically induced primary lymphedema mouse model to see the diagnostic capability of this technology. So here we have the wild type is a normal mouse, mutant is a diseased mouse. We can clearly see the drainage pattern changed for this diseased mouse. So for the wild type, the drainage pattern is follow the regular or normal predictable pattern. Go to the this sciatic, this is iliac, and go to the gastric lymph node. This is central lymphatics. And then at this point, this is about 8 minutes. Then the inguinal lymph node showed up. Then later on, we have the axillary lymph node showed up. So this is from central lymphatics to periphery lymphatics. For the mutant or diseased mouse, there's the key observation is there's no inguinal lymph node and axillary lymph node showed up. Another prominent difference is in the diseased mouse, we can see some lymph node. This is, we call it alternate lymph node. We don't know it's a new lymph node or it's the lymph node is not activated in the normal mice. So here, like I label is the A1, like this one. This one is above the sciatic lymph node. All right. So here in the normal, normal mice, you don't see this lymph node. Then again, we do the quantitative analysis, and this alternate this lymph node actually showed much higher the pumping the amplitude. We think probably this is compensatory mechanism, because the diseased mouse lymphatic system get impaired, so the body just find a way to drain the lymph efficiently, all right, to the lymphatic system. So we think this may be the direct observation of the compensatory mechanism for impaired lymphatic system. So we also did all this the pharmacokinetics and toxicity study of the probe. This is for the translational purpose. So here, just briefly talk about this. We see is this agent will they get out from body through feces, and the biodistribution is mainly in liver, but even in liver, after 5 days, we only have 5% of injected dose. Basically, is in 5 days, the majority of the agent get out. Also, this is the degradation study. We see the first day, the first 24 hours, the nanoparticle is stable. After that, it will gradually degrade into copper and selenium ion. So this is toxicity study. We inject the agent at 2 times and 5 times dose, the imaging dose, and we monitor the mice for 28 days. Also, we measure this. We did the blood test to see the liver function and kidney function. It's at a 5 times imaging dose, we see a little bit toxicity. We think that's probably because of the overdose of the copper. So generally speaking, this nanoparticle is safe and is biodegradable. So I think that's important for later on when we do the clinical, when we do the translational study for human use. So I think that's all I want to demonstrate to you. So, or the effort to develop this image. But let me finish by showing our latest development. This is we continuously developing this agent. This is copper nanoparticle it's a pure copper. It's not copper cyanide. You can this nanoparticle has very high specific radioactivity. You can clearly see the lymph vessel. This is the lymph vessel from tail to sciatic lymph node, and from the sciatic to the iliac lymph node and to the gastric lymph node. So this from the dynamic imaging, you can see actually you don't need a long time to see this lymph vessel. So it's several minutes. You can see this lymph vessel. So this is our the latest development. We just got this image last month. So actually, that's all I want to say. Let me show the last slide. Is actually I'm just present these results, and these people from UT Arlington and from UT Southwestern. This is UT Arlington. There's 3 PhD students of mine and Kelly Ablash at UT Southwestern. They did all these experiments. All right, that's it. All right, thank you for your attention.
Thank you. Great presentations. I think we'll open it up for discussion. So if you have a question, you can either raise your hand and I'll call on you, or you can just unmute yourself and ask your question. And I'll get the discussion started, I guess. Really beautiful work, especially the last slide too. I think that was the first time I had seen the pure copper compound in this really nice visualization of the lymphatic vessels. So with this agent, you've done a hind paw injection and a tail injection. Are there any sort of limitations as to where you can inject? And is there a way to actually mask the signal from the injection site?
So, we tried different injection sites, but so far is actually only tail injection give us this beautiful images. We tried the thigh into the thigh muscle. Somehow it didn't go to the lymphatic system. It's just stuck in the injection site. So that's something we have to try different location to see whether we can do injection in other places.
Thank you.
Hi, everyone. That was a really wonderful presentation by both of you. I really enjoyed both parts. I have a bunch of questions, but I'll start with one that was related to the one that Dr. Dellinger just asked. And that in some of the contrasts in humans, some of the problems with injecting peripherally is sort of the time that would then take for that contrast to reach the central system. And I'm wondering if you have any idea about the stability of this compound as you start, and what are your next steps in trying to think about that? Because I assume that this would be a really great thing to try to translate to the patients.
Yeah,
Yeah.
great question. I'll take a stab and let Dr. Howe add on. We do have experience with clinical imaging where we inject the peripheral lymphatics. For example, we can inject the feet and then we can image the central lymphatics, and it can be very slow. So if you're talking about Lipiodol, for example, these are painfully so slow to the point that oftentimes these imaging exams are not performed because it takes so long for the agent to go through the lymphatic system. Lipiodol is very viscous, it's very thick, almost sticky. It's a good agent, it has its uses, but there are those limitations. Lymphoscintigraphy similarly can take a long time, especially in a diseased lymphatic system. And that's a larger particle size that we typically use for lymphoscintigraphy in the United States. So it's a filtered sulfur colloid commonly, and it can go up to 200 nanometers. So part of what we're pursuing is to try to optimize that size so there is a more rapid movement through the lymphatic system, even in a diseased lymphatic system, so that way we can operationalize this imaging technique.
Yeah, we try to make the nanoparticles or the hydrodynamic smaller. So now we stick to this PEG 1000. The size is about 20 nanometer. So for the copper nanoparticle here actually is about 10 nanometer. We see is a much faster movement of these smaller particles. Yeah, of course, this is in mice. We don't know in humans. But we expect it should be much faster than the current that sulfur colloidal the agent. Yeah.
Thank you.
Great talk. Yeah, this is Joyce Tang from Stanford. I have a question. Whether you have had a chance to look at different tissue in mice and post-injection follow them to see whether these nanoparticles are causing any inflammatory changes in different organ system tissue. We've learned, from the dermatology standpoint, that in the past we weren't aware some of the MRI agent, for instance, causing nephrogenic fibrosing disease in patients, especially in patients who do not have a great, they don't metabolize these particles as fast. So it's a bit of a concern, or, when their immune system are not functioning the normal way. And then there are other human conditions that actually changing the metabolism of a copper particles. And in enzyme deficiency, such as Wilson syndrome and other condition, and how, yeah, that's a, I'll stop there and wonder what your thoughts about that.
We only did liver and kidney. We look at the this is the liver and the kidney. We didn't see the any obvious effect on the liver and the kidney. Also, the blood test. This is a test the kidney function and the liver function. We see this these parameters are similar to the control, but one parameter indeed decreased a lot. This is at 5 times. So this is an enzyme, I believe. So this one is we think it's because we have the high dose of copper, and this enzyme require zinc to function. So then this enzyme will take the copper as zinc. So that makes this enzyme function it's not right. So that is only in these 5 times we see significant drop of this this enzyme. So for the biodistribution, so mainly is almost all is in liver. Actually, we have a very small level of nanoparticles in other organs. So this is what we have done for the toxicity study.
I'll just tag on. Thank you, Joyce. Your question's critically important. If this isn't safe, it doesn't matter how great of an imaging it can do, or the power of the technology. You bring up some great points, about prior contrast agents like NSF that we've seen with older MR contrast agents, and specifically thinking about using copper in patients who may have altered copper metabolism, right? So that would be something that we would have to take very seriously. I would make the argument that the goal for our design is that this nanoparticle will break down into PEG and copper, which is a micronutrient in the body. And so in theory, there's an opportunity for this to be safe, but it has to be clearly demonstrated. And this is slightly different from the gadolinium agents, right, that we use for MR. And so, but you're right, it's a key consideration.
Yeah, definitely.
Thank you. Thank you so much. It's a great work and very, very exciting and interesting. I brought that point and I wonder if you would consider looking at PK for a different organ tissue as well. For example, the example that I used, like for a Wilson disease patient, there a lot of the precipitation happens in the brain and the liver, and they're not always equally distributed in different organ system. And with the lymphatic circulatory system being so fine, and the retention time and PK might be different in different organ system. So just a quick comment. Yeah. Thank you.
Great. Thank you so much. Thank you.
Well, if there are no additional questions, I just want to thank you both once again for a great presentation and for sharing this real cutting edge technology to image the lymphatic vasculature. So thank you.
Thank you.
Thank you.
Bye, everyone. And we'll see you next month for another presentation.